Welcome to our 5th annual Patient and Family-Centered Care for Pancreatic Diseases. We are broadcasting live from the University of Michigan Medical Campus. I am going to go over some announcements and give you a little bit of an overview of the program before we kick off to what I think is a very exciting program extending what we've accomplished the last 4 years. This is our 5th year. We've developed the pancreas program content in response to attendees' interests, so please let us know what you want to hear. We've selected an exceptional group of panelists and speakers, similar to our prior years. We've had growing interest over the course of our 5 years, with last year's attendance reaching a peak of 256 registrations from 40 states and 5 countries. Thank you all. We'd also like to be expressing thankfulness for the generous support of our sponsors who have helped to make this possible. In this virtual webinar format, attendees have been asked to submit questions electronically through the registration site prior to the meeting. The panelists will answer selected questions as they pertain to the specific theme they're covering. Unfortunately, we're not able to accept live questions, which has been a strength of our past live programs the first 3 years. Please respond to pre- and post-event communications. We have 9 true-false questions. We ask you to complete them both before and after this event. Those who complete both of the true-false questions will end up being in competition for a drawing of prizes. We also asked you to pay attention for requests to suggest topics for next year's events. We take these suggestions seriously. Approximately 2 weeks after the event, you'll receive an email notification about access to online video of today's event, as well as an electronic syllabus. This is the same as we did for last year's event. If you look at the QR code and use your scanner in the lower right-hand corner, you will connect with a Michigan Medicine Digestive and Liver Health page. And if you look on the right-hand side, there will be links to both connect to the video as well as the electronic syllabus. This is how we'll be doing it this year as well. Please mark your calendars for next year's event, our 6th annual event, which will take place in October. With good fortune, this will be a live event again, as we've had the first 3 years at the Inn at St. John's. The program has 3 parts. We will first begin with some updates, both from the Michigan Medicine Comprehensive Pancreas Program and then the National Pancreas Foundation Michigan chapter. The next portion is a focus on increasing understanding of the relationship between abnormal digestion and pancreatic diseases, and then ways to improve or maintain nutrition. We'll have a panel discussion answering questions that were submitted ahead of time, have a 15-minute break, and then move on to the second half of the program, in which we'll highlight genetic causes of pancreatitis, pancreatic insufficiency, and pancreatic cancer, and discuss what happens during genetic counseling sessions. We'll close with another round of panel discussion, answering questions, and then I'll have a brief set of closing comments. We couldn't have done it without you. We'd like to express a great deal of thanks to all of you who are in attendance, also to our partners, AbbVie, Chiesi, Nestle, and Vivus, thank you. Also our planning group, both the Michigan Medicine Comprehensive Pancreas Program, as well as the National Pancreas Foundation Michigan chapter board members. I'd like to express particular thanks to Vicki Vincent, our board secretary, who's been our jack of all or Jill of all trades, helping to make things happen. The next presentation is going to be by my colleague, Dr. Richard Kwon, who's going to discuss the Michigan Medicine Comprehensive Pancreas Program. Dr. Kwon is an associate professor of internal medicine at the University of Michigan, where he's been faculty since 2005. He is a pancreatologist, interventional endoscopist, in short, an expert in the breadth of pancreatic diseases. He has co-authored or authored numerous papers and chapters. He has received grant funding for studies particularly focused on pancreatic cystic lesions. He is an active member of multiple major pancreatic and GI associations. And for us, most importantly, he's a board member of the National Pancreas Foundation Michigan chapter. Without further ado, Rich.
All right. Good morning, everybody out there in the interweb. We are very pleased to welcome you to the 5th annual Patient and Family-Centered event for pancreatic diseases. We really hope that next year we will be in person together. The only disclosure I have is that I am part of a research study with AbbVie. So our comprehensive pancreas program represents the culmination of an attempt to organize and formalize our pancreatic care here at U of M, particularly within the gastroenterology division. We were established in 2018. The 4 pillars of values that we hold very dear and work very hard to maintain include providing world-class patient-centered clinical care. We pride ourselves in multidisciplinary collaboration. We like to pride ourselves also in participating and leading in innovative research. And then lastly, we take lots of pride in providing education not only to patients and families, to other caregivers and students. With regards to clinical care, we have expertise and passion for all pancreatic disease. This includes chronic pancreatitis, autoimmune pancreatitis, and pancreatic insufficiency. We care for a lot of patients with acute pancreatitis and complications of acute pancreatitis, including necrosis and pseudocysts. We also have clinical expertise in cystic fibrosis-related pancreatic disease. We have a lot of passion for cystic neoplasms and other neoplasms of the pancreas, whether it be pancreatic or ampullary. And we also care about hereditary disease, whether it's hereditary pancreatitis or those patients with hereditary or familial pancreatic cancer. We're widespread in terms of where we provide this pancreatic clinical care. We have clinics in the Taubman Center and the Rogel Cancer Center, as well as our genetics clinic. We also have one off-site clinic in West Ann Arbor where we see patients with pancreatic disease. Like I mentioned earlier, pancreatic disease is ultimately multidisciplinary in nature, so we pride ourselves in collaboration with all of our colleagues throughout the hospital. These include colleagues in surgery, gastroenterology, radiology, pathology, oncology, endocrinology, as well as pain and behavior specialists. We really pride ourselves in having a good working relationship. That way we can provide the best care for our patients. One embodiment of what this entails includes a monthly benign pancreas conference that's multidisciplinary in nature. We have gastroenterology, our gastroenterology team seen here, including our 4 newest members, including Dr. Machicado, Dr. Carpenter, who just joined our faculty, and our 2 new stellar PAs, Daniela Schock and Leila Hanna. And we have this monthly conference where we also have the blessings of lucky to have our surgical colleagues join us, as well as our radiology colleagues, and we discuss all cases pertaining to benign pancreatic disease, whether it's pancreatitis or cystic neoplasms or things of that nature. We also have a weekly multidisciplinary tumor board in which we discuss cancer cases. Involved in this tumor board includes surgeons, gastroenterologists, radiologists, pathologists, as well as oncologists. We also like to pride ourselves in participating and leading innovative research with regards to pancreatic disease. We have multiple studies, multiple publications, and up to $10 million in funding for studies which include studies in chronic pancreatitis and pancreatic insufficiency. We're also looking at studies in acute pancreatitis, including complications, including necrosis and pseudocysts. We have studies related to cystic fibrosis and pancreatic disease and cystic fibrosis. And we also have grants in cystic neoplasms, solid neoplasms, as well as multiple studies going for patients with hereditary or familial pancreatic cancer. In particular, if you're interested in participating in your studies, we have what I've listed here is this contact information for Sarah Volk, who is our stellar study coordinator for cystic neoplasms and some of the solid neoplasms studies, as well as the phone line to the Rogel Cancer Center to be involved in our hereditary and familial pancreatic cancer. You could also reach Sarah Volk with regards to those studies as well. Lastly, we pride ourselves and take a lot of enjoyment in providing education with regards to pancreatic disease, not only in patient and family-centered events such as those today, but we also participate in CME events, both in the institution and externally at other institutions and even internationally. We're also involved in medical student research, education, as well as education for medical residents and GI fellows as well. And hopefully one day soon we will be able to launch our 4th-year fellowship for pancreatology. And so all of this culminates in our participation in the National Pancreas Foundation Centers of Excellence. We're the first in Michigan for not only pancreatitis, but also pancreatic cancer. We take great pride in being affiliated with the National Pancreas Foundation and providing good care for our patients. So I hope I've been able to establish that we've been busy and we've been productive. We here at the Michigan Comprehensive Pancreas Program are very honored to take care of patients with pancreatic disease and are very dedicated in doing so. So thank you very much. Next, I'd like to introduce our state chapter chair, the Venerable Robin Winke, who provides counseling care services at Winke Therapy in Troy, Michigan. She is a woman of many talents as a psychotherapist, social worker, crisis counselor, and she leads our chapter and heads our efforts, and we're very thankful. Robin.
Thank you, Dr. Kwon. The National Pancreas Foundation was established 24 years ago by Peter Bursick and co-founder Jane Holt. The mission of the foundation is to provide hope for those suffering from pancreatitis and also pancreatic cancer through cutting-edge research, advocating for new and better therapies, providing support, and advocating for new education for caregivers and healthcare providers. Our future programs include the Animated Pancreas Patient, the NPF Centers, Patient Support Community, Patient Education Events, and state chapters. Our current physician programs include research grant funding, medical education, National Patient Registry, and the annual Fellow Symposium. The NPF centers are centers that have been identified as treatment centers for patient referral based upon specific criteria at an approved NPF center. Patients can expect excellent multidisciplinary care and focus on the whole patient, which includes experienced oncologists, gastroenterologists, surgeons, dietitians, pain specialists, psychosocial support, and more. So the NPF centers, we are one of 34 in the National Pancreas Foundation as a state chapter. Our board members are patients, caregivers, and also healthcare providers. Our Michigan board has worked together to provide education events for patients that show support through our monthly support groups and our online support programs. We have engaged in fundraising activities annually. Currently, our Michigan support groups are on hold due to COVID concerns. The NPF continues to partner with Inspire, an online support group for healthcare wellness. We will continue to update on the Michigan Facebook page and also the NPF website. Fundraising is an important part of the NPF. The NPF has an annual Color It Purple Challenge and an annual Pancreas Bowl event. This year, Michigan Board has scheduled our first 5K annual Pank Walk. The walk will be held on November 13th, which is a Saturday, starting at 11:30 at Paint Creek Cider Mill. It will be a 5K for people that would like to actually come in person. We also will offer a virtual walk for those that would like to participate from home. Volunteers at the MPF are very important. The opportunity is available. Additional information is available on the website, along with resources, information about upcoming events. Thank you.
Thank you, Robin, for that wonderful overview. We'll next move on to our second portion of the program dedicated to pancreatic maldigestion. Our first speaker on this three-speaker part of the program is Dr. Erik Wamsteker. He is Associate Professor of Internal Medicine in the GI Division. He's been a faculty member since 2002. His clinical focus has been in the diagnosis and treatment of patients with benign and malignant pancreatic disorders and performs therapeutic endoscopic procedures. He served on national committees where he specifically focuses on the dissemination of new knowledge and education through the creation and updating of guidelines in pancreatic diseases. This includes the American Gastroenterological Association and the American College of Gastroenterology. He's also been a counselor for the Pancreatic Disorders section of the AGA for Digestive Disease Week. And then also relevant to this program, he's a board member for the National Pancreas Foundation Michigan chapter.
Good morning. I've been asked to define the first topic for discussion in our education conference today, maldigestion. This topic is very important to patients with pancreatic disease. I'm sorry, I forgot. I have no disclosures. Maldigestion is the topic that is very important to patients with pancreatic disease. Maldigestion is defined as impaired digestion. In other words, incomplete breakdown of food and nutrients in the intestine. Specific to this forum is that many patients with maldigestion have pancreatic enzyme deficiency, although maldigestion can be due to other enzyme deficiencies. For example, lactase deficiency, which leads to lactose intolerance. It is important to know the difference between maldigestion and malabsorption. Malabsorption is defined as impaired mucosal absorption of nutrients from the surface of the intestine into the bloodstream. This is generally due to maldigestion or diseases that lead to defects in absorption or transport from the intestine into the bloodstream. To further clarify the differences in these terms, because they are often used interchangeably, is that maldigestion is one cause of malabsorption. It's important for us to know the symptoms that patients may experience if they have maldigestion: diarrhea, flatulence, bloating, cramps, weight loss, and abdominal pain. Although these symptoms are nonspecific and do not always indicate an impairment in pancreatic function, in patients with certain pancreatic diseases, this will prompt an evaluation for a pancreatic cause for these symptoms. So what are the primary causes of maldigestion? Exocrine pancreatic insufficiency. Maldigestion occurs with loss of greater than 90% of exocrine pancreatic function. And pancreatic diseases that can lead to exocrine pancreatic insufficiency include chronic pancreatitis, pancreatic surgical resection, and cystic fibrosis. Other diseases that are associated with maldigestion include certain liver diseases, small intestinal bacterial overgrowth, and enzyme deficiencies in the small intestine, lactase deficiency. So what are the complications of pancreatic maldigestion? Weight loss, muscle wasting, osteoporosis, visual disturbances, and neuropathy. And this will be discussed further by Amanda Lynett, our keynote speaker. To treat this, now that we know that there are significant potential complications that can result from pancreatic maldigestion, treatment is very important. Treatment is directed at the underlying disorder with the goal of replacing deficient enzymes. Pancreatic digestive enzyme replacement, or PERT, during meals and snacks is extremely important in correcting the abnormality. Pancreatic enzymes are dosed by lipase units, with the recommendation being 90,000 lipase units per meal, and half that dose with snacks. When patients are having problems achieving resolution in symptoms, when enzymes do not appear to be working or stop working, confirmation that the appropriate dose of pancreatic enzymes are being applied and timed appropriately so that the enzymes can mix appropriately with food. And in the event that that's been confirmed, consulting with your provider for evaluation for other potential disorders that can also lead to maldigestion would be important. So screening for and treating maldigestion may reduce symptoms as well as reduce long-term complications, so that would be the goal. Now, with that said, we'll move on to our patient testimonial, which will be done by Georgianne. Again, we're fortunate to have the opportunity to hear from her about her remarkable experiences. She's a patient who receives care at Michigan Medicine, and until she began her journey with pancreatic disease, she was employed by United Auto Workers. Currently, she serves as a patient advisor on numerous committees and boards at Michigan Medicine, all aimed at improving the lives and experiences of patients.
Finding out I had chronic pancreatitis was really difficult because I didn't even know what it was. I didn't know where my pancreas was. I didn't know what my pancreas did. So it was kind of scary to hear that. And exocrine pancreatic insufficiency is kind of a scary word, scary phrase, I should say, because you're not sure what it is. And you hear insufficiency and you're wondering, what does that mean? Can that be fixed? How will this affect me? The word chronic, you realize this is going to be long-term. So it has impacted your life by having to navigate that, having to have your family on board. It changes my work life changed. I had a wonderful job at the UAW, was planning to work there until I was ready to retire because of the pancreatitis, had to disability retire. Wasn't my plan. So that changes things, which of course changes things financially in your household, emotionally, because you feel like a failure. You have to stop working, you're causing a burden financially and things of that nature. So it does change your life in that regard. My overall health change with EPI, I wouldn't say there's a change. I think there's more of an awareness. I know why things are happening now. And I think that's been helpful because you know why, stool is loose or the way you're feeling, or you're having trouble digesting certain things. So I think it's more of an awareness than it is a change. Treatment for EPI is in pill form. I take pancreatic enzymes, which helps. But that was not an easy road. We had to determine how many enzymes with meals, how many enzymes with snacks. And along the journey, that had to change to fit my specifications. I take 6 with meals and 3 with snacks. So it's not difficult to take the pills. It's more difficult to know you always have them with you. If you're out socially and you're going to have dinner, you have to make sure you have your supply with you. So when you get diagnosed with something like this, it doesn't mean that you're diagnosed, this is what you do, and for the rest of your life, there's no change. It's a journey. When you have chronic pancreatitis, it impacts your life because you don't know when the flare is going to happen. My ability to make plans has changed because you're always, concerned, will I be able to, fulfill the obligation? For me, though, as hard as that was and tough as that was, there was a couple year period of time there that I really thought that, wow, where's my purpose and what am I going to do? It opened doors that I never knew were there. I'm able to be a patient advisor. I'm able to speak not only for myself, but for other patients. So, when one door closes and another door opens, I really felt that I saw that with this. What I thought was my life, the way I knew it, changed because of pancreatitis, but other things opened up that are very fulfilling. You find your ways to make it work. And I think we live in a world where it's broken and you fix it. And when you have something chronic, you don't get fixed, but you learn to deal with it and you learn to have your best life because of it. My support system, as I say, it's the 3 F's. It's faith, family, and friends. And it makes a difference. It really, truly does to have people surround you through this. Not to feel bad for you. That's not what you're looking for. But are there to understand when you have to cancel something and understand that, to encourage, to ask questions, because it's a road that you're traveling and you're not sure where the next turn is going to be. I don't know when the next hospital stay is going to be. I don't know when I'm going to miss an event that I really wanted to go to because I'm in there. And like I said, the support is to me is key.
Thank you, Georgianne. I'd like to introduce our keynote speaker, Amanda Lynett, who is a registered dietitian here in the Division of Gastroenterology at Michigan Medicine, University of Michigan. Her clinical focus includes the low FODMAP diet for managing irritable bowel syndrome, exocrine pancreatic insufficiency, and gastroparesis, as well as providing other individualized nutrition counseling for a variety of gastrointestinal disorders. She has participated as invited speaker at national meetings on the topic of managing nutritional complications of patients with pancreatic insufficiency. This includes the 4th annual GI Nutrition Training Program for Registered Dietitians 2019, the 3rd annual Patient and Family Centered Care for Pancreatic Disease, and the May 2021 Digestive Disease Week meeting.
All right, so I'm Amanda Lynett. I'm a registered dietitian with the Division of GI and Gastroenterology and Hepatology. I'm one of the few GI dietitians. I have no disclosures to release. All right, so I'm going to briefly discuss an overview of the difference between screening and maldigestion, malnutrition, and then I'm going to go into some medical nutrition therapy. So to start with the screening and monitoring process, I always advocate for patients to always discuss at each visit with their provider to discuss any changes and symptoms, so whether they're having new onset of nausea, any changes in abdominal pain, or changes in their stool habits. I also tell them to let us know if there's changes in their enzyme dosing, how they're taking their enzymes, as well as lifestyle changes. If they're no longer having the same access to food, I like to discuss that with them, or if there's changes in their exercise routines. I also encourage patients to get annual fat-soluble vitamins checked, A, D, E, and K, as well as regularly checking their hemoglobin A1C, as diabetes is an increased risk with pancreatic diseases. And then periodically, we'd like to test other micronutrient in case of deficiencies. So if there is a change in weight and you notice a lot of weight loss, we may want to be checking into some of these deficiencies. and then also a DEXA scan because of the osteopathy and osteoporosis is an increased risk with pancreatic diseases. So these are some nutrition-related complications, and I like to show these here because you see there is a difference, and there are some that are just general malnutrition and the macronutrient deficiencies like weight loss. Muscle wasting can be from your protein deficiencies. And then you can also have some from micronutrient deficiencies as well, such as like edema, night blindness, and these are all things that could happen if these deficiencies aren't corrected. So this is a more detailed explanation of clinical manifestations that could happen from select micronutrient deficiencies. And I really think it's important for patients to always be telling patients even non-GI symptoms to their providers, because I recently had someone that was talking about having hair loss and they were dealing with some like dry scalpy skin, and we run ahead and checked their zinc level and we found out that sure enough they had a zinc deficiency. So it's important to be talking about even non-GI related symptoms with your providers. So I'd like to talk about the difference between malabsorption and malnutrition. So malabsorption is when the body cannot absorb the nutrients properly. So they actually aren't able to digest the nutrients properly, while malnutrition is the lack of the nutrients within the body, whether it's the lack of eating them or just not taking in enough. But malabsorption can lead to malnutrition. So it's one of the many causes of malnutrition. Malnutrition can happen for a number of other reasons, such as patients having a lot of GI symptoms and just not having a poor appetite, not wanting to eat, early satiety. It could be because of lifestyle factors, whether they're using tobacco or alcohol in placement of their caloric intake. It could be from the increased energy expenditure as well. So there's a number of things that can lead into malnutrition, and it's important to be notifying your provider of all these different, symptoms going on because of the risk factor. So now we're gonna dive in and spend most of our time talking about some of the medical nutrition therapy. So some dietary considerations. We like to consider adequate calorie intake because there is an increase in resting energy expenditure, and so patients often have an increase in calorie needs. And we want to make sure there's adequate protein going in. So making sure you're getting enough calories and protein is important, as well as hydration, as dehydration alone can be an independent risk factor of having some pancreatic pain. So we want to make sure you're staying hydrated and getting enough fluids throughout the day. So how are some ways we can increase calories? I like to focus on talking about smaller, more frequent meals. So rather than eating only 1 or 2 meals a day, focus on spreading your meal intake throughout the day. I tell people to keep foods and snacks with them so when they're on the go, if you think you're going to a 2-hour doctor's appointment and you don't need anything because you ate before you left the house, you should always pack something, make some trail mix, grab a granola bar, pack it with you in case there's some hiccups along the road and you have to get testing done or end up at the doctor's office for 6 hours. So the longer you go, longer periods without eating, the increased risk of you not getting enough of your calories and protein in for the day. I tell people sometimes simply setting an alarm on your phone to remind you to eat because you don't always have those hunger cues. So setting that alarm can help with all of that. And then also trying to batch cook when you're feeling like you have a lot of energy or on a day that you might have someone that can assist you to batch cook. And basing your meals when you're at the most hungry point of the day. So let's say you feel hungriest in the morning. That should be when you should try to scramble up an omelet and some eggs and make a bigger meal. If you know that later on in the day, it's not going to go as well and you're going to feel sick and need to grab more of a convenience food. And then also sometimes, not for everyone, but some people find that separating liquids from solids helps because your stomach's not filling up on those liquids. So that can sometimes help patients too. So if we're increasing our protein intake, so it can be as simple as like adding extra eggs into dishes. You can add some hard-boiled eggs on top of casseroles or other types of dishes of that nature. You can bake an egg into your oatmeal when you're making oatmeal to add some extra protein in. You can use protein powders, obviously. You can stir them into shakes and smoothies or yogurts. And also dry milk powder is another good one that people can use. You can make little energy bites with it to give you extra protein. You can add it into mashed potatoes because it's just more milk and giving you extra protein. And then I like to tell people you can throw nuts and seeds onto different dishes like salads or casseroles. Oatmeal, again, is a good one to throw some extra protein on. All right, so this is just a brief example of a sample menu. I'm not going to go through each meal, but it just is mostly here to show you guys that it is easy to eat like small frequent meals and that you don't have to be slaving over making a breakfast idea or a lunch, dinner, and snack. Like there are grab and go quick ideas. I mean, you can make a kebab and grill it in less than a half hour. So there are ways to cook so you're not spending hours in the kitchen. So when it comes to dietary fat, this is always, I feel like, a hot topic. Yes, dietary fat stimulates the pancreas to secrete digestive enzymes and can trigger pain. However, a low-fat diet that term can be controversial in the sense of like what is considered low-fat. I would say anywhere between 20 to 35% of your total calorie needs would give you enough fat throughout the day. Which ironically, that's what the American Dietetic Association recommends as a healthy diet, to consume about 20 to 35% of your calories from fat. So it doesn't mean, what does that mean when it comes to grams? That's about 40 to 55 grams in an 1,800 to 2,000 calorie diet. So it doesn't mean it's a no-fat diet. It doesn't mean it's a 10-gram-a-day fat diet. The important thing to recognize is that we want to be spreading that fat throughout the day. So you want to be consuming it at your breakfast, at your lunch, at your dinner. You want to be spreading it throughout. There is sometimes people ask me questions about medium-chain triglycerides. You know, there's little efficacy and research on them to show that they actually are helpful and useful. They're unpalatable, and they can sometimes have the same side effects as to why people are looking to use them in the first place. So at larger doses, these MCT oils can actually cause nausea and diarrhea. So I often don't recommend them. And then the reason why we don't want to be on a no-fat diet or very low-fat diet, as I said, a lot of pancreatic patients are at increased risk of malnutrition. So a very low-fat diet is really pulling out a key nutrient from your diet and putting you at increased risk when you're an already at-risk population for malnutrition. So long story short, really should be avoiding any fat restrictions unless you're truly showing signs of steatorrhea. All right, so I will give some ideas for meal suggestions for modifying fat if you're having some steatorrhea or just some trouble digesting. So instead of eating a whole avocado or being afraid to eat any avocado, maybe just add a few slices to a meal. That could be something you could do. Or you could be using oils in place of butters when you're cooking. Or some patients even have trouble with the oils, and you can use like mashed fruit or applesauce in place of butter or oils when you're baking. And then some people find that like the creamy nut butters go better than like a actual nut itself because it doesn't take as long to digest in the stomach and goes through a little quicker, so the creaminess of it is easier. So the nutrition interventions I usually recommend. I usually talk about small frequent meals throughout the day. Doing well-balanced meals that always include a protein source, because as I had mentioned before, high calories, high protein is important. Avoiding unnecessary restrictions. So we shouldn't be Googling and seeing that, oh, something told me I should be avoiding X, Y, and Z food. Really, if you don't talk to your provider and find that you individually need that restriction. You should be avoiding as many unnecessary restrictions. You should be limiting or avoiding really fried foods or high-fat, greasy foods, because those can be the most aggravating to the pancreas. And meal prep ahead of time as much as possible. And always individualization, like talking with your provider to individualize it. You can use smoothies or shakes or softer diet texture when you're having a bad day, and then just go back to more solid foods when you're having a good day. So some other interventions that aren't always so food-driven is I do like to tell people that exercise is good. So light exercise does stimulate your appetite and can be helpful. Obviously, if you're diabetic, you want to be checking your blood sugars and following a consistent carb diet throughout the day. Sometimes with pancreatic diseases, there is some more of like the brittle diabetics, and diet doesn't always play a huge role, but it is important to try the best you can to be watching what you're eating and trying to eat consistently throughout the day and spreading those carbs throughout. You should be completely abstinent to alcohol and tobacco. You should work on sleep hygiene. That's important too. Getting adequate sleep affects our gut, as well as stress management. So sleep, hydration, stress, those all play a role in how our bodies digest food. And always individualization, like I said before, is key. So just a brief comment about vitamins and minerals. I do often recommend a general multivitamin for all my pancreatic patients. There are some water-soluble pancreatic enzymes that aren't always required, but a lot of our CF patients will take these. So they are water-soluble forms of A, D, E, and K. And then as far as the other vitamin supplementations, like I was talking before about my patient that needed zinc, it should be all based off of deficiencies. So we shouldn't be blindly supplementing someone with vitamin E or zinc or folic acid. I think they should be checked first to make sure you have a deficiency before you are supplementing, especially because some of these vitamins are fat soluble, which means that if you eat or take too much of it, it can become a toxic level in the liver if you're taking extremely high doses of them. So just a brief word about pancreatic enzyme use. It's important to be talking to your provider about pancreatic enzyme use and to discuss the meal pattern of which you will be taking them. So it's important to try to take the first enzyme with the first bite of food, take some in the middle of your meal, and then one at the end of the meal, rather than taking them all like a half hour before you start eating or while you're starting to cook your meal. The timing is ever so important. Another thing is important not to graze, because grazing makes it really difficult to dose your meals properly. So trying to stick with a scheduled meal pattern is best. And knowing that not every single food requires enzymes. So there are certain foods out there, like if you were to have just a 4-ounce glass of orange juice or a small apple, that doesn't require enzymes, and being aware of that. And lastly, you should always be monitoring your symptoms before you start enzymes. When you're adjusting dosages and talking with your provider about it, you should be having open conversations. If you're having a lot more diarrhea or less diarrhea and all of a sudden you're really constipated when you tripled your dose of enzymes, you should be having conversations with your provider about any changes in your symptoms. So the role of a dietitian, how do we kind of all play a role in this? We are normally the ones that are screening and monitoring for malnutrition. So we are the ones that are getting in, asking those questions. We try to get a very detailed background and an extensive history to learn more about it. We gather other pertinent information so we can provide an individualized interventions and individualized goals for the patient. So we talk about what will work best for the patient based off of their lifestyle, what kind of meal patterns work based or meal prepping will work based off of the individual's lifestyles. So these are some good resources, and I'll just leave this up for a second if patients want to screenshot this, because these have some good resources for cookbooks from the pancreatic, there's a chronic pancreatic cookbook that's really good, and there's links included on this. So these are some good resources for cookbooks and other recipes. All right, thank you. All right, I'm going to jump right into the panel discussion then. So I'm going to start with my questions here. So the first question I have is, what do you suggest for diet in those with pancreatic insufficiency, and what is the ideal diet? So I would really say that's, like I was saying before, it's kind of individualized, but I find that in general, like a Mediterranean style diet works best. So trying to eat a diet that's low in red meats, higher in your whole grains and your fibrous foods, you're getting more plant-based sources, trying to limit the ultra-processed foods, the ultra-fried foods is really the best. That's probably the most ideal diet. There's actually a really good, this might be the next question, but there's a really good cookbook from the American Test Kitchen about the Mediterranean diet that has actual nutrient breakdowns of different foods. So it gives you how many grams of fat, how many grams of protein, how many calories are in each recipe, which patients like, especially pancreatic patients that are really watching and trying to get more protein in, or trying to watch certain grams of fats, the saturated fats. So the next question is, are there online menus or dietary recommendations? So I would refer back to those cookbooks that I was showing a couple slides ago on the resources. There's a really good one if you go to like the Pancreatic Foundation website. There's like a 56-page cookbook there. The American Test Kitchen Mediterranean Diet is a good cookbook as well. Or just meeting with your local dietitian to see if they can provide you additional resources. Are there foods that absolutely should not be eaten by a patient with pancreatitis is the next question. I like to say that no food is off limit as a dietitian. I'm not a food police, so I'm not one to take foods away. But I find that if someone knows that something's triggering to them, whether it be that they eat, every time they eat garlic, it's triggering, then that individual should avoid it. But across the board, really like the greasy fried foods, the deep fried foods with a lot of saturated fat, or like a really gristly steak, should probably be limited. I'm not going to say avoid forever, but should be really limited and eaten sparingly. All right, the next question is, what are the top 5 foods to avoid in those with chronic pancreatitis? So this is kind of similar to the last question, in the sense of there isn't certain foods that should be avoided. If I were to really talk about food in general, I would say maybe try to be careful with like deep fried things that are using a lot of lard or butter, because those are going to be more aggravating and trigger the pancreas and cause more pain. So staying away from really deep fried things that might have increased saturated fat. What foods are beneficial to those with chronic pancreatitis? It's a good question. So I think eating a lot of protein would be really beneficial. So calories, high calorie, high protein is good. Including some anti-inflammatory type foods. So if you want to include berries or spinach or nuts, kale, like those are all good. I think it's good to get that. Get some fermented foods in your diet to help increase the short chain fatty acid production, could be good too. So fermented foods would be like, you could do kimchi or yogurt. Those are some good examples, but I think just eating a variety of food, diversity is really probably the best thing to be including in your diet. So trying not to be restricted and having a very diverse diet. All right, so do specific foods contribute to maldigestion? This is a great question, and I think this answer would be very individualized, because maldigestion is usually due to a lack of enzymes, so certain enzymes in the body. So certain foods for someone might be lacking like the lactase digestive enzyme, so they might have trouble with like lactose intolerance, or some individuals have trouble with like a sucrase digestive deficiency, enzyme deficiency, which would give them trouble with certain fructose containing foods. But in general, like specific foods could be, it's very individualized depending on what they're maldigesting. If it's general, like if they're feeling like they're just having a lot of steatorrhea and it's more pancreas driven, I would probably tell people to be careful with like the super high saturated fat foods again, because that could make the maldigestion worse. So be focusing more on like leaner cuts of meat, more, fiber sources, stuff like that. So the next question is there a rule of thumb for nutrition in those with both acute and chronic pancreatitis? So I would say if you're having a really bad day in both the acute or chronic phase, and you're having a tough time and a lot of symptoms, that a softer food, softer textures can be a little easier. So it's okay to do a couple days where you're doing more of a liquid-based diet. That is a good thing. But in general, just trying to keep diversity. So trying not to put too many food rules on yourself, and kind of keep things varied as much as possible. The next question says, how do I make an appointment to see a registered dietitian? So if you are a patient at the University of Michigan, you can either self-refer or ask your provider to schedule an appointment with a dietitian. If you want to see a GI-specific dietitian, you do have to ask your provider. So you would ask your doctor for a referral. There are 3 GI-specific dietitians on staff, and then we have about 8 more that see GI patients that you can self-refer to. So you don't actually have to have a Michigan medicine provider to see a dietitian. You can self-refer yourself by calling any of the clinics, like West Ann Arbor, East Ann Arbor. You could call the clinic and self-refer yourself. There are some websites too. One is IFFGD. If you are out of state and looking for a dietitian, they have resources of dietitians within every state. So that could be another good resource. Next question is, I have pancreatic insufficiency. Should I take a multivitamin and other supplements? So as I had stated in my presentation, I do usually recommend a general multivitamin for most of my patients with pancreatic diseases. And then for additional supplementations, I would like to have the patient get all their labs drawn first to make sure there's a deficiency and a need for additional supplementations before just blindly supplementing. And then I have pancreatic insufficiency and am losing weight. What can I do to gain weight? So the first thing is we need to check, and if you're not on enzymes, get you started on enzymes. That would be the first thing. If you are on enzymes, maybe we need to be adjusting the dosage of enzymes and how much you're taking, because that is probably going to be the key solution to help you gain weight, is because you're still probably malabsorbing. Or you could be underfueling yourself and just not getting enough calories in overall. So kind of net in, net out. If you're not getting enough in, you're not going to gain weight. So that would be where working with a dietitian to make sure we're increasing your calorie needs. So you're getting maybe like 30 kcals per kilogram rather than the standard like 25. Might be necessary to increase an extra like 300 to 500 calories a day to help you promote weight gain. I have back pain and a fracture of my spine. Is this related to my maldigestion? So that's a good question. I mean, it could be because you might have developed like osteoporosis, and that could have been because, a DEXA scan can check for that. And that could have been because your body for so long, so many years, were unable to digest nutrients. So that would be important to get that addressed right away and corrected, so before further fractures would happen. So that it could be the case, but it doesn't necessarily guarantee the case. The best thing is to get a DEXA scan checked to see if there is any osteopathy going on. And then the last question is, I have pancreatic insufficiency and diabetes. Will taking pancreatic enzymes make my blood sugars go higher? So taking pancreatic enzymes is going to correct any steatorrhea, maldigestion. So it's going to help, so your body's finally absorbing the nutrients that it was lacking before. So in theory, when your body starts absorbing nutrients, it will maybe make your blood sugars go a little out of whack at first, but they should regulate itself. And with the adjustments of diet too, that can help regulate it as well. So it shouldn't long-term make your blood sugars go high. And if it does, that's where you should really talk with the dietitian or adjust your meal patterns. Maybe you were overfueling to make up because you were losing so much weight, and maybe you don't have to be taking in so many calories, and your body can be sustained on lower calorie intake at this point. So, all right, I think that's the rest of me. I think we have Dr. Wamsteker next with questions.
Hello again. I'll read the questions and then I'll attempt to answer them. So the first question is, does pancreatic insufficiency or exocrine pancreatic insufficiency mean you have chronic pancreatitis, or can you have pancreatic insufficiency without having pancreatitis? Although pancreatic insufficiency is most commonly caused by chronic pancreatitis, you can have exocrine pancreatic insufficiency without chronic pancreatitis. Disorders of the pancreas, including pancreatic cancer and the effects of cystic fibrosis, can lead to pancreatic insufficiency. Pancreatic surgical procedures that involve some type of resection of a viable exocrine component of the pancreas can also lead to pancreatic insufficiency. The second question is how often does pancreatic insufficiency develop in those who have chronic pancreatitis? Reviewing the literature, the estimates are somewhere between 35 and 80%, and the reason there's variability is because there are different causes of chronic pancreatitis. What we do know is that patients that have certain risk factors for the development of chronic pancreatitis, like alcohol and or tobacco use, are much more likely to progress to developing pancreatic exocrine insufficiency. And up to 80% of those patients will go on to develop exocrine pancreatic insufficiency. Whereas patients that have idiopathic forms or perhaps certain genetic forms there may be a lower likelihood of progressing to develop exocrine insufficiency. Question number 3 is, do my chances of developing exocrine pancreatic insufficiency increase with the number of attacks of pancreatitis? That will depend on the severity of an attack or the cumulative number of attacks that a patient has over their lifetime. For many patients that develop either a particularly severe attack of pancreatitis or over a number of years with increasing numbers of attacks of acute pancreatitis, they'll go on to develop chronic pancreatitis, and under those circumstances will be more likely to develop exocrine insufficiency. Question number 4 is, what is the typical progression from diagnosis of chronic pancreatitis until exocrine pancreatic insufficiency appears? This too is somewhat dependent on what is felt to be the cause or risk factor for the development of chronic pancreatitis. So when alcohol and tobacco are the primary risk factors, most patients progress to EPI in approximately 13 years. And again, there are different studies, so that progression may be somewhat different, but 13 years is the ballpark figure that people would use in alcohol and tobacco induced chronic pancreatitis. And those with an unknown cause typically progress in a median of 26 years to develop exocrine pancreatic insufficiency. So how is question number 5 is, how is pancreatic insufficiency determined? Well, it's determined on the basis of objective tests that have some pros and cons to them. Traditionally, 72-hour fecal fat collection could provide medical professionals with an understanding of whether pancreatic exocrine insufficiency was present. This test is difficult, and it's difficult because patients have to eat a high-fat diet and have to accurately quantitate the amount of fat that they're ingesting over approximately 5-day period, with the last 3-day period being when patients would collect stool. It's really a measure of fecal weight and fat content with up to 7 grams of fat when patients are eating a 100-gram fat diet daily. Up to 7 grams is normal. This test is difficult also because it's a measure of fat content, which is really an indirect measure of pancreatic function. So the most common test currently used for measuring pancreatic exocrine function is actually a fecal elastase, which is a single stool specimen, and it measures an enzyme that's stable in the intestines called elastase. The test is very specific in that if patients have a formed stool specimen and they have low elastase, it's a fairly accurate test for defining whether patients have pancreatic insufficiency. I would say that that's probably now the most common test that's used for making a determination of whether pancreatic insufficiency is present in the United States. Question number 6 is, I was diagnosed with mild to moderate severity pancreatic insufficiency, but don't have any symptoms. What should I expect? Again, the future may be somewhat dependent on the patient's risk factors for exocrine pancreatic insufficiency. And assuming that the diagnosis is correct, then patients typically would need to be monitored carefully for complications of pancreatic exocrine insufficiency. In patients that have substantial risk factors for exocrine pancreatic insufficiency, treatment with pancreatic enzyme replacement therapy may be in those particular patients' future. Question number 7 is, I have chronic diarrhea, normal appearing pancreas, but low fecal elastase test. The report states I have mild to moderate pancreatic insufficiency. Why don't pancreatic enzymes help me? Well, in this particular circumstance, presumably that test was ordered and they were started on pancreatic enzymes. If they legitimately have pancreatic exocrine insufficiency, then the pancreatic enzymes that they were placed on may not work because they weren't given appropriate doses. But more than likely, if a patient has chronic diarrhea and has little to no risk factors for true risk factors for pancreatic exocrine insufficiency, the diagnosis using perhaps a fecal elastase is incorrect. In other words, you can have a falsely abnormal fecal elastase because you have loose or watery stool that dilutes out the elastase content, and so that's more than likely the cause. It's a falsely abnormal fecal elastase test. Question number 8 is, how do you know if pancreatic digestive enzymes are working for you? Well, this depends on whether you have subjective symptoms suggestive of pancreatic exocrine insufficiency. So if you have abdominal pain, bloating, diarrhea, and you're given pancreatic enzyme replacement therapy and your symptoms get better, meaning the diarrhea goes away or the abdominal pain and bloating go away, you may be able to objectively determine that you're benefiting from those enzymes. In some cases, if the diagnosis is a little bit more difficult or a little bit more insidious, then your medical provider may need to be able to obtain objective measures of nutrition as a way of being able to monitor you for response to pancreatic enzyme replacement therapy. And then question 9 is, what is the correct amount and timing of taking pancreatic enzymes? The correct amount would be approximately 90,000 lipase units. So pancreatic enzyme tablets or capsules are typically dosed according to lipase units. Although the enzyme tablets in capsules typically not only include lipase, but they include proteases and amylase enzymes. The lipase units is how they're actually dosed. So patients should be taking approximately 90,000 lipase units per meal. And as Amanda had mentioned, what you want is the enzymes to actually mix with your meal. So depending on the number that are actually prescribed to you, you would want to take one in the beginning, perhaps one in the middle and one at the end, or one in the beginning and one at the end, depending on the number of capsules that you would take for those meals. So question number 10 is, how helpful are pancreatic digestive enzymes? Well, in patients with exocrine pancreatic insufficiency, pancreatic enzyme replacement, it replaces the necessary digestive component that the pancreas ordinarily would serve. So the intention here is to really avoid the downstream long-term complications of maldigestion or malabsorption. And so not only can the enzymes replace or relieve symptoms that are related to maldigestion, but if we as the medical establishment are proactive in making early diagnosis, we may well be able to limit the long-term complications such as osteoporosis or muscle wasting. Question number 11 is, my gas and oily stools improved, but only partly while taking pancreatic enzymes. What else can I do to improve my symptoms? Again, the idea here would be to ensure that you're taking appropriate doses of digestive enzymes. It unfortunately is not that uncommon that digestive enzymes are either underdosed or not properly dosed. So patients may be taking too few capsules with their meals, so they need to make sure that they're taking proper doses. And if the amount of enzyme is truly appropriate, then they may require additional testing, which would require a discussion with their provider. A fairly common associated disorder, small intestinal bacterial overgrowth. There can be reasons that patients would have ongoing gas and oily stools if they have other factors that contribute to maldigestive type complaints, concomitant lactose intolerance or fructose intolerance may cause similar symptoms that overlap. So I believe ensuring that you have that discussion with your provider, that would also potentially provide an explanation for why you'd only get a partial response. Question number 12 is, if there is no pain without taking pancreatic enzymes, is the pancreas continuing to be damaged? Treatment of pancreatic exocrine insufficiency actually may not alter the natural history of chronic pancreatitis. It may allow for avoidance of complications of the downstream effects of untreated maldigestion or malabsorption, but as to whether that will affect the natural history of pain related to chronic pancreatitis remains in question. It is likely that a component of abdominal pain may come from underlying pancreatic exocrine insufficiency, and so patients may experience some degree of pain relief, at least of that component of their symptoms, but ongoing damage is potentially not altered by actually taking those digestive enzymes. Question number 13 is, what is the consequence of not taking pancreatic enzymes? Untreated maldigestion or pancreatic exocrine insufficiency has the potential for propagating the complications that we've discussed previously: osteoporosis, muscle wasting, unexplained weight loss, visual disturbances, neuropathies, which in theory could be avoided with early treatment of exocrine insufficiency. So question number 14 is, how dangerous is it to have an occasional drink? It depends, I guess, on whether you have an underlying pancreatic disorder that is propagating pancreatic exocrine insufficiency. I think a careful discussion with your provider, if you have pancreatic disease, should occur. It probably will contribute to worsening disease, and it really depends on what the underlying pancreatic disorder you have is. So I know I'm punting that answer, but I think it really should just be an individualized discussion with your provider. At this point, we'll take a 15-minute break, and we'll return for the second half of the educational conference. Thank you.
Welcome back. I'm delighted to introduce the second part of our program for our 5th annual Patient and Family-Centered Care for Pancreatic Diseases. The second part of the program focuses on the genetics related to benign and malignant pancreatic diseases. For this section, I'm going to introduce my colleague, Dr. Elena Stoffel, who's the director of the Michigan Medicine Cancer Genetics Clinic. She's actually going to be your MC for the second part of the program, for which we have 3 speakers. Now, Dr. Stoffel is Associate Professor of Internal Medicine, Division of Gastroenterology. Her clinical and research interests encompass early detection and prevention of gastrointestinal cancers, as well as diagnosis and management of individuals with genetic predisposition. She is an NIH-funded investigator. She served in numerous leadership roles at Michigan Medicine and nationally. She serves on the ASCO Committee of Cancer Genetics and is a past president of the Collaborative Group of Americans on Inherited Colorectal Cancer. So with this expertise, I couldn't find a better candidate to speak to us today. With that, Elena.
Thank you very much, Dr. DiMagno, and it's really a pleasure to be with you today. And I am joined by two of my colleagues from our multidisciplinary cancer genetics clinical program here at Michigan Medicine. I have the pleasure of introducing our next two speakers who are going to give a joint presentation. Tannaz Guivatchian is one of my colleagues in the Division of Gastroenterology. She is an assistant professor of internal medicine, and where she has been on our faculty since 2015. She is a general gastroenterologist, but her area of specialty is in management of individuals with hereditary susceptibility to cancer. She will be joined by Andrea Murad, who is our lead genetic counselor in our cancer genetics clinic. Ms. Murad's research spans a broad swath of topics in genetic medicine, including health disparities in genetic counseling and returning incidental findings as part of genetic testing and research studies. She's currently vice president of the Michigan Association of Genetic Counselors and is the vice chair of the Practice Guidelines Committee of the National Society for Genetic Counselors. We are very excited to take the reins for this next part of the presentation, which deals with some case examples of how genetics can be very closely involved in the diagnosis and management of hereditary diseases associated with pancreatic disease. All right, I'm going to, it's my pleasure to introduce first Dr. Guivatchian.
Good afternoon, everyone. Thank you so much for having me here today. So in the next 25 minutes or so, my colleague Andrea and I are going to talk about several case examples of pancreatic diseases that we see in our genetics clinics. After that portion, I'm going to actually hand things off to Andrea, who's going to give you all an overview of genetic testing as well as genetic counseling. And I would go so far as to say probably the genetic counseling is the most important part of a visit with us in our genetics clinics. So let's begin with several case examples. And the first case I want to present is regarding the topic of chronic pancreatitis. So for those of you who may not be familiar with chronic pancreatitis, that is when there is ongoing inflammation in the pancreas that has now become irreversible and is leading to more permanent changes and damage within the pancreas. As a result, individuals can develop chronic abdominal pain, and they can also develop insufficiency of the organ. So this can fall into exocrine pancreatic insufficiency, which we heard about earlier, where the pancreas does not produce the digestive enzymes to break down food, or it can be endocrine insufficiency, where we're not producing enough insulin now and we can't regulate the blood sugar. Whenever we see an individual with chronic pancreatitis, as physicians, we would really like to identify what the underlying cause for their chronic pancreatitis was. This list is by no means comprehensive, but I just wanted to give everyone a sense of some of the thoughts that we have when we see a patient in our clinics. So there are, of course, environmental factors that we know can be associated with chronic pancreatitis. So both smoking and alcohol can play a role and can actually progress the disease as well. There can be some anatomic factors and chronic medical conditions. So individuals with diabetes or celiac disease are at risk for developing chronic pancreatitis. Any sort of autoimmune condition of the pancreas can also lead to chronic inflammation and chronic pancreatitis. Hypertriglyceridemia is elevated levels of fat in the blood, and that can also be a risk factor. Of course, genetic and hereditary causes, which we are going to be focused on today, also are in our list of possibilities. I did want to bring your attention to the last row, which is idiopathic, and that's the word we use when we are basically saying we're not sure exactly what has led to the diagnosis. And we can break down this group a little bit further by age. So individuals with early onset chronic pancreatitis, so those who have developed their disease in their 20s versus later onset pancreatitis. We have found that often up to 50% of the time in that early onset idiopathic group, there is an underlying hereditary or genetic cause. So this is a list of several of the genes that we do test, and when we're considering an underlying hereditary cause of chronic pancreatitis. PRSS1 is probably the most well-established one, and we know that not only does it put individuals at risk for chronic pancreatitis, but it can also increase their risk of developing pancreatic cancer as well. I'm going to point out CFTR, that's the cystic fibrosis gene, and if you have 2 abnormal copies of that gene, you have cystic fibrosis, and those individuals can be at increased risk as well. So let's talk about our first case. This is an actual patient that we saw in our genetics clinic. A 36-year-old woman is presenting with a history of chronic pancreatitis. Looking into her personal history in more detail, she actually had her very first episode of pancreatitis at the age of 26 and had a total of 10 hospitalizations related to pancreatitis. By age 27, imaging is now showing evidence of chronic pancreatitis, and the patient is actually started on pancreatic enzyme supplements. And by age 35, imaging is now showing atrophy of the pancreas. And that basically means that on imaging, the pancreas appears to be shrinking down as she is losing normal, healthy tissue of the pancreas. In addition to her pancreatitis history, she also has a history of diabetes, as well as high cholesterol that was diagnosed at a fairly young age as well. In terms of additional risk factors, she was a non-smoker, and she had no heavy alcohol use history. So in our clinics, in addition to focusing on an individual's personal history, a really important aspect of our clinic is to focus on family history. So her family had a very interesting pattern. So first of all, her mother had had an episode of pancreatitis. And in addition, she had both a maternal aunt as well as her sister with chronic pancreatitis as well. This next slide, we're not going to be going through it at all, and it's really not meant to overwhelm anyone, but I just want to give you all a sense of how in-depth the family history that our genetic counselors will obtain in our clinics can be. So they will actually develop a 3-generation family tree during the visit, and our patient is the one circled in red. So now that we've seen this patient in clinic, we have to decide whether or not we think she would be a good candidate for genetic testing. And so when we're trying to make this decision, we're first looking at the patient's personal history. And factors that raise our suspicion for a hereditary cause include a younger age of diagnosis. So she was in her 20s when she developed her chronic pancreatitis, and that raises our suspicion. Then also we look at family history. And in family history, we're looking to see if there is a pattern of multiple individuals with that condition, so in this case, chronic pancreatitis or other related conditions. And again, we do also look at the ages, with younger ages being more suspicious for a hereditary cause. So because of her personal and family history, we did offer genetic testing. And she was found to have a pathogenic variant or mutation in the SPINK1 gene. We know individuals who have a mutation in this gene are at 6 to 12-fold increased risk for developing chronic pancreatitis. We also know that individuals with this particular pathogenic variant in this particular gene can also be at increased risk of developing pancreatic cancer. So in these individuals, if they additionally have a family history of pancreatic cancer, we would actually offer them pancreatic cancer screening with various imaging modalities. I'm not going to go into the details of pancreatic cancer screening right now, but Dr. Stoffel, who's going to be following us with the keynote, is going to go into great detail and explain what we do when we screen the pancreas for cancer. In addition, in our clinic, whenever we identify an individual with a pathogenic variant in a gene, we will also offer genetic testing to family members. And our goal really here is to identify all of the individuals in the family who are at increased risk and try to intervene early to minimize that risk as much as possible. So in this case with chronic pancreatitis, we would counsel additional individuals in the family to avoid some of those high-risk behaviors, such as smoking or alcohol consumption. So we're going to move on now to the second case, and I'd like to present a case of pancreatic cancer. So looking at the risk factors for pancreatic cancer, you can see there is overlap with the discussion that we've already had regarding chronic pancreatitis. So we know that advanced age or older age, and smoking play a role in increased risk of developing pancreatic cancer. There are certain medical conditions such as diabetes or obesity that also increase an individual's risk. Any form of chronic pancreatitis or the hereditary pancreatitis that we just discussed can also increase an individual's risk of developing pancreatic cancer. And then additionally, diet and alcohol, we feel, also play a role. So looking at the potential genetic causes of pancreatic cancer, here's a list of the various genes that we often test for when we see patients in our clinic. As you can see in the last row, we've already discussed the genes related to hereditary pancreatitis, but there are some additional categories. So we know that the hereditary breast and ovarian syndromes, and BRCA1 and 2 or BRCA1 and 2 are genes you may have heard of. These can increase an individual's risk of developing pancreatic cancer if there is a mutation or variant in the gene. There are additional conditions such as familial melanoma or Peutz-Jeghers syndrome that we know also increase an individual's risk. And finally, Lynch syndrome, which is one of the more common hereditary syndromes in the general population, also increase an individual's risk of developing pancreatic cancer. So let's look at our second case. This is a 34-year-old gentleman who presented to our clinic with a diagnosis of pancreatic cancer or pancreatic adenocarcinoma. And prior to this diagnosis, he was healthy and he had no other significant medical history. And specifically, he had no history of pancreatitis, diabetes, or high triglyceride levels. He also did not have a history of any of the more high-risk behaviors, so no smoking history and no significant alcohol use in his history. In addition to his personal history, we of course are focused on family history in our clinic. And we're once again seeing a pattern that is concerning. So his mother had had pancreatic cancer at the age of 51, and her brother, so his uncle, had had pancreatic cancer at 29 and actually had passed away at age 39 at a very young age. His maternal grandmother had breast cancer, and his sister had actually passed away from jaw cancer at 24. Once again, our genetic counselors will get that in-depth family history and develop a 3-generation family tree. And our patient is again circled in red. So reviewing this case, we once again have a patient who has a history of cancer at a very young age, and that increases our suspicion for an underlying hereditary cause. And in addition, his family history, we're seeing a pattern of multiple individuals with pancreatic cancer, and again, diagnosed at fairly younger ages. So we did offer this gentleman genetic testing, and he was found to have a mutation or a pathogenic variant in the CDKN2A gene. And this gives him a diagnosis of familial melanoma. And we know individuals with mutations or pathogenic variants in this gene can develop pancreatic cancer up to 15% lifetime risk, and therefore we do offer them pancreatic cancer screening. In addition, we know there is a significant risk of developing melanoma, so we do recommend meeting with a dermatologist once a year for a full head-to-toe skin check to try to minimize that risk. And again, we offer genetic testing to his family members. Our goal in this clinic is to identify as many people that are high risk as we can so that we can offer the appropriate screening early and try to catch any lesions before they turn into cancer or at very early stage when they are still treatable. So now I'm going to ask Andrea, my colleague Andrea, to come up and give her portion of the presentation.
Thanks, Tannaz, and thank you for having me here to discuss some genetics background with you all today. I am going to start with just a very quick overview and background on genetics. We're not going to go too deep into the weeds here, but having some terminology for the future part of the presentation today will be super helpful. So this is probably kind of a reminder of your high school biology class, but when we talk about genetics, we're talking about our germline genetics, and our germline are what we are born with, so our DNA that's in every single cell of our body. And I really like to think of our DNA as our body's instruction manual. So just like an instruction manual contains all the instructions you need, that's what our DNA is for our body. And just like instruction manuals can be broken down into smaller sections, our DNA can be done the same way. So chromosomes are the structures that hold our DNA, and if you zoom in and look closely at those chromosomes, that's where you'll see genes. And I like to think of genes as kind of the smallest instructional unit of genetic information in our body, and that's really what we'll be talking about with these inherited conditions today, is changes at the gene level. So who are genetic counselors and what is genetic counseling? It is almost 100% of the time that I meet with people and they tell me they've never heard of a genetic counselor, never met with a genetic counselor, and that's really common because it really isn't something that people go through every single time they see a physician or have any other healthcare appointment. So genetic counselors are healthcare professionals. We're mid-level providers, so not physicians, not nurses, and we're kind of smack dab in the middle. And we have training in both genetics and in counseling. And the reason that we have training in both is that the genetic side of our training is to help identify if an individual or their family members, the diagnoses and things we're seeing could be due to a genetic or an inherited cause. And then the counseling side comes in and is really important because if we identify a genetic condition in a family, that often comes with a lot of adaptations to life and emotional things. And so that's where our counseling background comes in really handy. Our role as part of the healthcare team is to provide guidance to individuals who are trying to make decisions about their genetic health. And so we see individuals sometimes as part of a team, but sometimes individually as well. In our case here, we work as a multidisciplinary team, as Dr. Stoffel mentioned, with physicians and genetic counselors. And the goal of what we're trying to do is try and interpret the family history and personal history of an individual to see if there is an increased suspicion for a genetic or inherited susceptibility syndrome, and then guide individuals through that whole process of considering genetic testing, what that may or may not tell them, figuring out what is the right choice for them at the right time as far as proceeding with genetic testing or not. And so in a genetic counseling visit, there's really quite a wide range of how long the visit could take. I would say on average, I would expect it to take at least an hour, but there's some are as short as 30 minutes. Typically what will happen during that visit is a lot of talking. So the genetic counselor will sit with you and review your medical history. And as Dr. Guivatchian said, we take a really detailed family health history. We discuss why you were referred to our clinic and then do an overall risk analysis of what we're seeing in the personal and family history to determine whether or not genetic testing may be appropriate or be informative for an individual or their family. And we review lots of different things as far as what decisions might need to be made that day for the person and their family, and provide guidance for them to help understand if genetic testing is appropriate, what tests are the most appropriate for them, and help them to choose what the right path forward is for them. The one thing to note is that that decision is going to look different for every person who sits in front of us. So some people will want to proceed with genetic testing, some won't, and their reasons for doing so are going to vary widely. So I'm going to talk a little bit more about the family health history because, as we mentioned, that really is an incredibly important part of our genetics evaluations. So as Dr. Guivatchian showed you, the picture that's there is called a pedigree. This is a way for us to draw out family relationships in a way that gives us a picture so that it's easy to do a risk analysis of that family history. And it's, we gather things about medical and health information about both the individual and their family members. And so in the pedigree, you see people are connected by both horizontal and vertical lines, and those are relationship lines. It allows us to document things like individuals who are living or deceased. So the diagonal lines across some of those individuals show that they're deceased. It allows us to document gender and sex assigned at birth, if people are adopted or if they're biologically related in a family. We also document things like pregnancy losses or current pregnancies that are ongoing, half siblings, full siblings, and all of that can be depicted pretty easily and seen in a picture. By drawing that picture out, it gives us clues as to whether or not there are conditions that may run in the family and helps us to identify other people in the family who also might either be at increased risk for the condition or alternatively, who might be the better person in the family to begin the genetic testing or genetic evaluation with. So if you're going to see a genetic counselor, have a genetic evaluation, it's really important to try and collect some family history before you come in. Now, we certainly see people where we don't have tons of family history, and that's okay, but ideally we like to get as much information as we can. And so generally speaking, prior to going to your genetic counseling visit, it would be good for both your maternal and paternal sides of the family to try and collect information about all relatives, so how old they are, or an estimate if you don't know the exact age. If anybody has passed on, we would want to know approximate age of death and what the cause of death was. Specifically in terms of cancer histories, it's really important for us to know if a family member has had cancer, what type of cancer that was, and where their cancer originated, and their age at diagnosis. On top of that, if any of those family members with cancer have actually undergone genetic testing, that's a real important piece of our puzzle when we're doing our genetic evaluation. And generally speaking, in collecting family health history, you want to pay attention to any conditions that occur in more than one individual. You want to make note of lifestyle or environmental exposures, such as smoking history or any heavy alcohol use. We want to know countries of origin on both maternal and paternal side of the family. So we're commonly told, like, oh, my family's been in the United States for a very long time, and that's probably true. But we still like to know where your family came from before they came to the United States. And then making note of any family members who are blood relatives to one another that may have married each other. And so after we go through collecting the family history, we have a long discussion about genetic testing and what it can and cannot tell us. So when we talk about genetic testing, as I mentioned previously, we're talking about the germline genetic testing. And so that's the changes in our DNA that we are born with and that don't change throughout our lifetime. For most people, germline genetic testing will be done using a blood sample, although it can also be done on a saliva sample for some. And in a rare set of people, it needs to be done on a skin biopsy sample because we can't use a blood sample. But once that sample is collected, it's sent off to a genetic testing laboratory, and they do what's called next generation sequencing. And what I mean by that is, if you recall, our genes are just a long string of letters. And so what they're truly doing is they're looking and reading along the sequence of every single gene that we ask them to test for, looking for single letter changes, and looking for any deletions or duplications within those genes. And when we do our genetic testing, we can get one of three possible genetic test results back. The first possibility is that we get what we call a positive genetic test result, and that means that we identified what is called a pathogenic or likely pathogenic variant, sometimes also referred to as a mutation, in a gene that we tested. And what that means in regular terms is that there is a variation in one of your genes that isn't allowing that gene to function as it should. And so that gene change can often provide a diagnosis and explain why somebody has developed the condition or symptoms that they did. And it can also identify whether or not that individual could be at risk for developing other cancers or other things and would therefore need additional screenings of other parts of their body. The next option is that we could get a negative genetic test result. And the most confusing thing about a negative genetic test result is that it does not necessarily mean not genetic. What it means is that in the genes that we know of and understand today to be associated with the condition that we tested for, we did not identify any changes or variations in those genes. We have over 20,000 genes in our body, and it's certainly possible that there are other genes out there that maybe contribute to inherited risk that we just don't know about. And so it could be that there's a variation in a gene that we just haven't discovered, and so therefore we wouldn't have tested for it. It could be that maybe our technologies just can't detect those changes, but it could also mean that maybe your diagnosis of cancer or whatever you came in to test for was something that just happened by chance or was sporadic. The third option with genetic testing, and one that I think some people worry about, even though I don't think we typically worry about in the genetics community, is something called a variant of uncertain significance. And what that means is when we did the genetic testing, we did identify what is typically a single letter change in one of the genes that we tested. But currently, there is not enough information about that specific change to know if it impacts the way the gene functions. And so we can't say if it's benign or if it's disease-causing. What we do know so far to date is that when we find a variant of uncertain significance, about 85% of those turn out to be benign, and that's typically why in the genetics community we don't worry too much about them until we have more information to go on. So one of the biggest questions we get during any genetics evaluation is whether or not insurance will cover genetic testing. And I know everybody wants this to be a very easy yes, no answer, and unfortunately it is not that easy. Every insurance company and every policy within insurance companies is very different. So all I can tell you is that some insurance will cover genetic testing and some will not. Even if your insurance does cover genetic testing, it's going to be subject to things like copays and deductibles, just like all other things that you deal with within the healthcare system. The nice thing to note is that many commercial genetic testing labs will perform what's called a benefits investigation to determine what an individual's estimated out-of-pocket cost will be. And many of them, not all of them, but many have a policy such that if your out-of-pocket cost is expected to be over $100, they will contact you, at which point you do need to contact them back to discuss what options you have for that genetic testing. And those options could be things like if the lab offers financial assistance, canceling the testing, or even maybe switching to a self-pay price that does not go through insurance. And some labs do offer self-pay prices, somewhere in the range of $250 to $300. Not every lab will, but some will. And so those are important questions to ask during any genetic counseling or genetic evaluation. And so what does it mean for you if you're diagnosed with an inherited condition? The biggest thing is that this is likely going to result in some changes to your health management and your surveillance. So specific guidelines or screening recommendations would potentially exist, and we would make those recommendations moving forward in conjunction with the physician you would be seeing to know how to manage you moving forward. It would also mean kind of identifying a healthcare provider that's familiar with your condition. And so our clinic is a cancer genetics clinic. That's one area where we manage individuals diagnosed with these. High-risk cancer clinics can also be good ones. Or identifying a specialist in your area who is familiar with your condition, whether that's a gastroenterologist, gynecologist, obstetrician, or geneticist. And then if you're unable to find somebody on your own, genetic counselors are really great resources to help you try and find a provider who understands your condition in your geographical area. The other thing we recommend to everyone is that you become an expert in your condition. You're going to be your best advocate within the healthcare system. And so knowing the ins and outs of what the condition is really important. And that happens during your genetic counseling session where we provide you with a lot of information and medical management recommendations. We encourage everybody to keep a chart or binder to track those recommendations. And it's specifically important because if you move at some point in your life and go to a whole new healthcare system, you have all that information there to share with your new providers. Keep in mind, too, that everybody's specific management plan will vary. They may not be the same, so we have general recommendations that we make for these conditions, but each person and each family history is unique. And so because of that, there will be general recommendations, but your own care will be tailored to you and your specific situation. The other part that we haven't talked about is what does this mean as far as the emotional health. So identifying a genetic condition in an individual can often come with lots of emotional changes for individuals. And it's not uncommon for people to wonder if they're the only one with a specific condition. We offer lots of information on different support groups and patient advocacy groups that individuals can reach out to. Some of those are online, some are in person. It's also not uncommon for people to feel overwhelmed with the number of decisions and doctor's appointments that they might be needing. And so we really encourage people to lean on their resources, such as social workers, genetic counselors, or psychologists to help them navigate those new things that are coming at them. And then with inherited conditions and non-inherited conditions, we always recommend having eating a healthy and having an active lifestyle to reduce cancer risks, don't smoke, and then drinking alcohol in moderation. So the next question we get is, and this is pretty common for people, is I'm not here for me, I'm here for my family members. So what does this mean for my family members? And so if a genetic condition is identified in you, especially in the world of inherited cancer susceptibility syndromes, most of these are inherited in a dominant manner. And so that would mean that all of your first-degree relatives would have a 50% chance of inheriting the condition as well. And your first-degree relatives include your parents, your children, and your siblings. And so we always encourage everybody to communicate this information to their family members so that they can pursue genetic testing on their own if that's the right choice for them. Because genetic testing helps us to identify who in the family inherited the condition and therefore needs enhanced screening, and who in the family didn't and therefore would likely just need the general population screening. And so a few last takeaways to remember when it comes to genetic counseling and genetic testing for inherited susceptibility syndromes is to remember that support is available, not just for you in dealing with your own diagnosis and medical management, but in helping you communicate genetic information to your family members. We know this can be a complicated thing, and not everybody feels comfortable talking about genetic information. And so we do provide things like family letters, try and help have group discussions with family members if needed. And so your genetic counseling team and your genetics clinic are a great resource for those things. We are a community and we are here to help and provide you all and your families with information that you need. And we always encourage people not to give up. We know that communicating information to family members is difficult and sometimes family members don't want to hear the information you're sharing with them. But the goal is that genetic testing can identify who needs increased screening aimed at early detection and of cancer and saving lives. And so we're here to support you in that role. And so with that, I'm going to pass this on to Dr. Stoffel for her keynote address.
Well, thank you very much, Andrea and Tannaz. And as it's really my pleasure to kind of give the keynote address to try to bring all of this together and illustrate how knowing about your family history and sharing this information with your healthcare providers can actually help not only take care of you, but take care of your family as well. So precision medicine is defined by the National Institutes of Health as an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. In sum, this is looking to answer the question of what treatment is best for me, for each patient. The objectives of this section is going to be to look at how pancreatic disease and genetics can intersect and how this can impact screening recommendations, treatment recommendations for certain diseases, as well as the ability to prevent the diseases from affecting other family members. The case example I want to start with is a true story that happens again and again. My sister was just diagnosed with pancreatic cancer. What, if anything, do I need to do? And what do we need to do as a family? This diagram actually shows where we are with regard to genetics and cancer risk. We know that cancer is incredibly common, and statistically, 1 out of every 3 people will be diagnosed with a type of cancer sometime in their lifetime. However, there is a certain proportion of cancers that are caused by the inherited factors that Dr. Guivatchian and Ms. Murad were talking about, which are genes that are associated with an increased risk for cancer, so to speak, a first strike for developing cancer. And in the realm of pancreatic disease, for pancreatic cancer, we know that approximately 1 out of every 10 to 1 out of every 20 individuals with pancreatic cancer carries one of these gene changes that were the first strike to develop the cancer. This diagram basically outlines where we are right now with what we know about genetic susceptibility to cancer. And in the blue are the genes that have been associated with colorectal cancer risk. In the pink and purple are the genes that have been associated with risk for breast and ovarian cancer. And in the green are the genes that have been associated with pancreatic cancer. And as you can see here from this picture, these all intersect because all of these genes are related to mechanisms for repairing the DNA that is present in every cell of our body. And so if there are genes that are not working to repair DNA, it's more likely that DNA errors will happen. And that's fundamentally why cancers develop, is because there's something wrong with the genetic programming of the cell. Families with genetic risk are underdiagnosed. We often talk about the patients we see in our cancer genetics clinic are but the tip of the iceberg because these genetic susceptibility syndromes are actually surprisingly common, and most people don't know that they carry these gene alterations. Approximately 1 out of every 300 people carries a gene change associated with hereditary breast ovarian cancer, more commonly known as BRCA1 or BRCA2. For individuals whose ancestry is of Ashkenazi Jewish descent, the prevalence can actually be much higher, as high as 1 in every 40 people, which is one of the reasons why Ms. Murad was explaining that we often ask, where is your family from? Because there are certain parts of the world where certain gene alterations can be more common. 1 out of every 300 people also carry gene changes associated with a condition called Lynch syndrome. Lynch syndrome is associated with risk for hereditary colorectal and gynecologic cancers. And again, given that 1 out of every 300 people carries this gene change, most people out there who are at risk for this condition don't know that they have it. 1 in every 100 people carries a gene change in the ATM gene, which is one of the minor genes associated with increased risk for breast cancers as well as pancreatic cancers. And 1 out of every 31 people carries an alteration in the CFTR gene, which is associated with risk for cystic fibrosis when you carry 2 altered copies of the CFTR gene. But 1 out of every 31 people carries an alteration in the CFTR gene. So that's, again, much more common than anybody really thinks about. So how do we identify and intervene early in families where there's a first strike to develop a disease? So in this slide, I want to review kind of what constitute the red flags for possible hereditary syndromes. And as was mentioned previously, when someone is diagnosed with a cancer at an unusually young age, or when somebody develops pancreatitis at an unusually young age, that is kind of the first red flag. The average age for pancreatic cancer diagnosis in the United States is 65. As you heard from some of the case presentations, we had someone diagnosed with pancreatic cancer at 34, which is much younger than the average age of diagnosis. Similarly, when children or young adults develop pancreatitis, that's another red flag. Also, for individuals who develop multiple different types of cancer in a single person, that's another red flag. And then looking at families, when we find that there are multiple family members that are affected by the same or related conditions, as we've heard, breast and ovarian cancer tend to go together in families that have BRCA alterations, colorectal and endometrial cancer in families that have Lynch syndrome, young breast cancers and prostate cancers in families with BRCA alterations. Pancreatic cancers are a red flag in and of themselves because many individuals who carry gene alterations for pancreatic cancer really don't have a lot of other cancers in their family. And then finally, as we described, families in which there are multiple people who develop pancreatitis raises a red flag. So let's go back to our case of my sister recently diagnosed with pancreatic cancer. What, if anything, should my family do? So in this family diagram, you actually see that in addition to the sister being diagnosed with pancreatic cancer, the mother and the mother's brother were also diagnosed with pancreatic cancer, which makes a huge difference because here we see we see 3 relatives with the same type of cancer in the family. And in this family, genetic testing in the sister revealed a pathogenic germline variant, so an alteration in the BRCA2 gene. And this information was extremely helpful in guiding the management, not only for our patient with pancreatic cancer, but actually for her family members as well, because it made it possible to test other individuals in the family to determine whether they did inherit this gene change that is associated not only with a risk for pancreatic cancer, but more importantly, with risks for breast cancer, ovarian cancer, and prostate cancers as well, which could potentially be prevented. So why is this important? Well, for the patient with pancreatic cancer, it's really important because we know now that there are certain treatments that work better for patients who have certain genetic changes. And in particular, with pancreatic cancers in people who have alterations in the BRCA genes, there are new medications called PARP inhibitors, which can actually prolong survival and improve outcomes. But also for other family members and for our patient's 2 brothers and sister, as well as multiple other cousins, this is an opportunity to be able to offer genetic testing that will determine whether they did or did not inherit this gene change. Women who inherited this gene change would be eligible for enhanced breast cancer screening. They would be at risk for ovarian cancer. Men and women, men would be screened early for prostate cancer, and men and women would be eligible to start pancreatic cancer screening with the hope of identifying an alteration early enough to change the natural course of history. So let's talk a little bit about pancreatic cancer screening. in general, as you know, there are recommendations for the general population to screen for breast cancer, to screen for colorectal cancer, because we have excellent data that screening for those cancers actually reduces morbidity from those cancers and improves survival. In screening for pancreatic cancer, we're in a little bit of a gray area with regard to the general population. The average person's risk for pancreas cancer is less than 1% over the course of their lifetime. However, for families that have a genetic susceptibility to pancreatic cancer, that risk can be 4-fold to 20-fold higher. And for patients for families that meet those criteria of being in that higher risk group, pancreatic cancer screening is a reasonable approach, because the hope is to detect a lesion before it becomes clinically evident and before it is big enough to have metastasized. So our goal in screening for pancreas cancer is to identify patients whose personal and family history put them at increased risk for developing pancreas cancer, and actually looking at the pancreas before symptoms ever develop. We can look at the pancreas using MRI of the pancreas, as you can see in the bottom image. We can also look at the pancreas using an endoscopic ultrasound approach to be able to look for solid lesions. These two complementary modalities, the MRI and the endoscopic ultrasound, when used together, can help us identify when there is something going on in the pancreas that's not entirely normal. There's still a lot of uncertainty as to which of these lesions are the ones we worry more about, which of the lesions we worry less about. And for that reason, it's recommended that individuals who are eligible for pancreas cancer screening be screened in centers that have this expertise. And we are really fortunate here at Michigan Medicine to have such a center with experts in gastroenterology and radiology, as well as surgery, to be able to review the images and decide on the next steps. We are all working towards finding better ways to detect pancreatic disease early, and certainly it's our hope that someday there will be a test that is very highly sensitive and specific. And certainly we are working with investigators, we're collaborating with investigators from all over the United States, as well as international groups, looking for these early detection markers. And we are really very grateful to all of our patients who are involved in helping us with this research. With regard to early detection and prevention, again, who should be screened for pancreatic cancer? So individuals who carry specific germline gene changes that are associated with the highest risk for pancreas cancer. These include individuals with the CDKN2A gene change that Dr. Guivatchian mentioned, as well as with gene changes associated with other hereditary susceptibility syndromes. So individuals who have gene changes in genes such as the BRCA1, BRCA2, ATM, and the Lynch syndrome genes, if they have a relative with a pancreatic cancer diagnosis, then they meet the criteria for pancreatic cancer screening. And finally, individuals who have 2 or more close relatives with pancreatic cancer meet criteria for screening, even if there is not an identifiable gene change in the family. Because it's important to reinforce what Ms. Murad was saying, in that sometimes there are a lot of cancers in the family and we're not able to find a genetic cause. But that doesn't mean that one doesn't exist, it just means we're unable to find it. And then finally, individuals who have hereditary pancreatitis, as was mentioned, are at increased risk for developing pancreas cancer as a result of chronic inflammation in the pancreas. And so these are certainly individuals that we should also talk to about screening. There's a lot about genetics in the news, and I think what you've heard today is probably a lot more detailed than what is presented to the general public. We hear a lot about tests that you can order, and you can order tests and learn your ancestry, and you can order tests and learn what type of wine you like, and other traits that are kind of popular interest. But it's important to remember that genetic testing is not all the same, and these genetic tests, it actually makes a difference who is doing the genetic test and what the genetic test is looking for. In this article from the New York Times from a few years back, it just compared that that there are a lot of laboratories out there. There are some of them that are doing genetic testing more for fun and recreation, and there are some that are doing more genetic testing that is clinical grade genetic testing that your physicians and other healthcare providers would rely on. So not all genetic tests are clinical genetic tests. So who should undergo clinical genetic testing for pancreatic disease? With regard to pancreatic cancer, to review, every individual who is diagnosed with a pancreatic cancer at this time is eligible for germline genetic testing, because as I mentioned, up to 1 in every 10 to 1 in every 20 pancreatic cancer patients carries one of these gene changes that would make a difference for families. Certainly members of families where there are multiple individuals affected, as well as individuals who meet criteria for familial pancreas cancer, which is basically 2 or more people in the family. And then the close relatives, parents, siblings, children of pancreatic cancer patients who may not have had the opportunity to have genetic testing would also be considered eligible for genetic testing. With regard to pancreatitis, certainly individuals who have recurrent pancreatitis, unexplained pancreatitis, and have a family history of relatives with pancreatitis would meet criteria. Children and young adults who have unexplained episodes of pancreatitis that is recurrent. And certainly, as was mentioned previously, there are genes associated with hereditary pancreatitis that we test for. So what influences whether a person gets genetic testing? And this is something that we think about very much in our clinic because, as I mentioned, we know that we're seeing only the tip of the iceberg. We're seeing only patients who have asked the question, could there be something genetic in my family that's contributing to the disease? And so we continue to work very hard with our colleagues across multiple centers across the state of Michigan as well as internationally to look at what can we do to make genetic testing more approachable for families that would benefit from this. And we're involved in a research study with the help of the Michigan Department of Health and Human Services and with the help of the National Institutes of Health to try to make this information more available to patients, families, and their healthcare providers. And Michigan is very fortunate to have a cancer genomics branch at the Michigan Department of Health and Human Services that actually has a genetic hotline that patients and healthcare providers can call if they have questions about genetics. And cancer risk. So, as Ms. Murad mentioned previously, you know, some patients say, well, I don't want to know this information. This is not, I don't want to know. And I think I do want to take a minute to explain that, you know, genetics is not your destiny. DNA is not your destiny. It merely provides us an opportunity to look ahead to figure out what things we can do now that will prevent disease from developing in the future. And certainly we know that there are a number of different factors that impact risk for developing disease. Certainly genetics is one factor, environmental exposures and health behaviors are other factors, and there are things here that we can control. You know, we talked about screening and being able to start looking early to try to prevent things from developing. We've also talked quite a bit about smoking and about the role that smoking plays in pancreatic disease, as well as the risk for multiple types of cancer. We know that there are other things like the microbiome and inflammation and things that can impact risk, things that we may be able to change if we knew in advance what we needed to do in terms of health behaviors and in terms of medical treatments to act early. And certainly, of course, diet plays a role, as you've been hearing again and again. Good nutrition is fundamental. So in summary, I hope this group of talks today has empowered you to talk to your medical team about your family health history of not only of pancreatic disease, but of other diseases, because it's important to determine whether your personal and family history meets criteria for genetic testing for some of these inherited conditions for which we could act early and change the natural course of history. Genetics is not your destiny, but it can provide important information for your care. Certainly, it can help us change treatments, change behaviors, and change the track of the course of the disease. So on that note, I wanted to thank you all very much for listening to us today. And I think we're going to move on to the questions that have been pre-submitted. So for this part of questions, I'd like to call Dr. Guivatchian back up to the podium.
Okay, so question number 1. 2 of my mom's brothers died from pancreatic cancer. I have chronic pancreatitis from high triglycerides and severe pancreatitis. Do I need cancer genetic testing? So I think, the short answer is yes. I think you would, this individual would be someone that we would like to see in our genetics clinic. Once you're in clinic, we would get more of that in-depth history and have really a good discussion about sort of whether or not we think that you meet criteria. But when we have multiple individuals in the family with pancreatic cancer and an individual with an underlying pancreatic disease, again, we're seeing that pattern that may raise the concern for a hereditary condition. So we would offer genetic testing for this patient. Question number 2. I suffer from recurrent attacks of pancreatitis beginning at age 22. My doctors call this idiopathic. Should I have genetic testing? And the answer again here is yes. So as we talked about, idiopathic is the term that we use as physicians when we don't really know why you've developed this condition. But in early onset chronic pancreatitis that is idiopathic, or recurrent episodes of pancreatitis that is idiopathic, we have found that a good portion of these patients will have an underlying genetic or hereditary cause. So again, I do think this would be a case where we would offer genetic testing. I'm going to ask Andrea to come up and answer the following 2 questions.
Okay, so the first question is, what are the pros and cons of genetic testing? And these will in fact vary from person to person. There's no one right way here. Some of the pros, as we've talked about, of genetic testing is that it may open up the door for other treatments for somebody if they have a cancer, an active cancer diagnosis. For their family members, it will help us to identify who else in the family could also be at risk for developing the same condition and needs enhanced screening. But an equal benefit is who in the family is not at risk, so did not inherit that, and therefore will go back to the general population screening. Some people are just information people, and they really like to have all the information they can have out there and know that they have kind of looked for all the things that could be the cause of something and know that they're doing everything they can. On the flip side of that is some of the cons are other people don't like that information, and that amount of information may feel overwhelming to somebody. The other thing is that other people may not want to know if they have an inherited susceptibility, and we go through all of these ins and outs in a genetic counseling session to try and determine what it is that kind of lands somebody more on this is information I want or this is information I don't want. Of course, some of the cons of genetic testing is that we can't guarantee that all insurance will cover genetic testing, and unfortunately, it's not free. Prices have come down over the years, but costs of genetic testing could be a con to genetic testing. I will say that one thing that's nice in the world of genetics is years ago there was a law passed called the Genetic Information Non-Discrimination Act, or GINA for short. That law actually is a federal law that says health insurance companies cannot use genetic predisposition information for discriminatory purposes. So if you're an unaffected family member who's found to have inherited the genetic variant in your family and puts you at an increased risk, that is not the same thing as having a pre-existing condition, and that information cannot be used. Certainly, that doesn't apply to all things like life insurance, long-term care, so that's another con to genetic testing, is that maybe there's other insurances that could be impacted, but again, these are all things that are thoroughly detailed in a genetic counseling session so that individuals can decide what the right path forward for them is. That takes us to question 2, where we talk about whether or not genetic testing is covered by insurance. And I did talk about this a little bit earlier, but there are some criteria out there that says who's eligible for a genetic evaluation. However, that doesn't necessarily mean that that's the same as the insurance criteria. So what I can tell you is, again, that some insurance will cover it, some won't. Many labs nowadays do offer self-pay prices that are quite reasonable. So genetic testing is always, I think, assumed to be exceedingly expensive. Prices are still high, so even the self-pay prices of around $250 are not a small amount of change, but much lower than what they were many, many years ago. Again, having a genetic counseling session does not mean you have to proceed with genetic testing. It's just your place to go to get information and get your evaluation and figure out what your next steps are. And so I would encourage everyone to ask those questions during their genetic counseling session, and then you decide at that point in time whether or not testing is right for you. But many of those questions will be answered during a genetic counseling session. Okay, for the next 5 questions, Dr. Stoffel will answer those.
So for the first question of who should undergo genetic testing, I put on one of the slides the red flags, but I think basically the bottom line is talk to your healthcare provider about your personal history and your family history of cancer or pancreatic disease. And based on certain criteria, which are established and part of national guidelines, your healthcare provider should be able to help you determine whether you meet criteria for genetic testing. The second question is, I have a cystic fibrosis mutation. Is this the cause of my pancreatitis, or should I be concerned about other diseases? As I mentioned in my talk, 1 out of every 31 people has a single gene change in the cystic fibrosis gene, so it's super common. And most people who have these single gene changes in cystic fibrosis don't have any symptoms or any sequelae from this. The major thing we worry about is when one individual who has a cystic fibrosis gene alteration meets another individual with a cystic fibrosis gene alteration, and they have a child that would then have a 1 in 4 chance of having a clinical diagnosis of cystic fibrosis. So for that purpose, I think knowing this information can be very helpful. With regard to risk for pancreatic disease, that's been a big question in the field for a very long time as to whether we find these gene changes in CFTR more commonly in people with a diagnosis of pancreatitis, or whether it's just kind of 2 things that are both true but unrelated. So I think that the jury is still out on that. But in general, as I mentioned, this is incredibly common and certainly information that does not necessarily predispose you to developing pancreatitis. So the third question is, how do the results of genetic testing change treatment? As I mentioned, that as we're learning more about the mechanisms by which diseases develop, we can actually learn more about how we can potentially treat those diseases. In the case of pancreatic cancer that has a BRCA alteration, we know that treatment with a PARP inhibitor, chemotherapy medication, can actually result in improved survival. There are a number of different conditions for which there are similar molecular targets that medications are able to target. The next question was, I was tested for genetic exocrine pancreatic insufficiency and the results were not clearly defined. Is this standard? So as we mentioned previously, genetic testing is not always definitive. Sometimes testing can reveal that there's a change in a gene that is of uncertain significance, and therefore we don't know whether or not this affects the gene function. We also know that there are probably other genes out there that can be associated with pancreatic disease that we haven't yet discovered. So a negative genetic test or an uninformative genetic test does not completely exclude a diagnosis unless there is someone in the family who has a gene change that is definitive, and then a family member is tested and found not to have that gene change. In that sense, that's really useful information and pretty definitive. I think in the case of exocrine pancreatic insufficiency, as we've heard, there are a number of different reasons why a patient could develop exocrine pancreatic insufficiency. And in particular, some of these gene changes that are associated with hereditary pancreatitis are basically only the first strike. Having that gene change doesn't guarantee that you're going to develop the disease, but it can be the first strike. So that's one of the reasons why genetics doesn't explain everything and is certainly not your destiny. And then finally, since I had genetic testing 6 years ago, have new tests been developed for detecting pancreas cancer? I already lost 4 family members to pancreatic cancer. So this is an excellent question because, as Ms. Murad mentioned, the field of genetic testing has changed tremendously over the past few years. And prior to 2014, whenever we did a genetic test, we were looking usually at only 1 or 2 genes, and we were looking at them using a certain technology. But after 2014, we now have next generation sequencing technologies, which can look at multiple genes at the same time. So depending on the type of testing that this patient had done 6 years ago, it is possible that there may be updated testing available, and I think it would be important to review the testing that was done previously to see whether it was testing just for 1 gene, because in the past, with a family history like that, we might have just looked for the CDKN2A gene, which is changes in that gene are much rarer than other genes such as BRCA, which we now know are factors in families with pancreatic cancer, whereas in the past we might have just looked at CDKN2A and not BRCA. So on that note, I want to pass it back to Dr. DiMagno for concluding remarks.
Before I finish up with the closing remarks, I just want to thank the audience out there for actually proposing this theme in the second part of the program. And I'd like to thank our speakers again, Dr. Stoffel, Dr. Guivatchian, and Ms. Murad for such a beautiful overview of this topic. So as both a thank you and a reminder, I'd ask you once again just to please, if you may, respond to the pre and post-event communications. This includes completing the 9 true-false questions pertaining to each one of these presentations. This is useful for us for planning purposes, and those who complete the questions before and after the event are eligible for drawing for prizes. We, again, welcome suggestions for future topics. This is reflected in today's educational event. And then look for your email. You'll see links for both the syllabus and the video, which will be available online, similar to last year. There'll be a link. There'll also be a QR code, whichever is most easy for you to use. We have a walk here upcoming on November 13th. This is at the Paint Creek Cider Mill. Beautiful fall walk, 5K. Please consider participating. And then again, we hope that this event, as well as past events, have been interesting and valuable to you. Please mark your calendars for next year. We hope to see you again next October. Thank you very much.